So Imad has given me the task of talking about diagnosis and management of gastric neuroendocrine tumors. In the interest of time, I'll try and make it simple and hopefully give you some practical tips on it so we can manage these on a daily basis. I have no disclosures. So these are my tasks for today. So I'll talk briefly on the principles of gastric neuroendocrine neoplasms, talking about the types, the grading, what tests we need to do to classify, and then how we manage it, and I'll share a couple of cases at the end. So we like the term neuroendocrine neoplasms more than neuroendocrine tumors because it encompasses both well-differentiated neuroendocrine tumors, which are the majority that the ones we see, and also neuroendocrine carcinomas. We know that these are biologically different, so neuroendocrine tumors are indolent and non-functioning, while the neuroendocrine carcinomas are very different disease. They're very rare, prevalence of 3 in 100,000, but we see them more frequent in our clinical practice, especially type 1, because of the higher incidence of chronic atrophic gastritis. But we know already that there is an increasing incidence of 0.4 per 100,000. But as I said, the majority of these lesions, fortunately, are well differentiated, and they are classified as grading G1, which we'll come to in a minute. So we classify them into type 1 to 3. Type 1 is associated with chronic atrophic gastritis, and these represent the majority of lesions we see, about 80%. Type 2 is associated with hypergastrinemia, which we see with Zollinger-Ellison syndrome, and also associated with type 1 men. These are about 5% of the neuroendocrine neoplasm, and type 3, which is the most important one, and the most aggressive one, is up to 20%. Clinically, type 1 frequently is less than 2 centimeters in size, and you almost never get angio invasion, and that's why they are favorable. Type 2, usually more than 2 centimeters, and angio invasion happens at a later stage. Type 3 can present in any size and almost always have angio invasion, so these tumors are very different. As we said, type 1 is indolent. The risk of metastasis is extremely rare, and they have an excellent long-term survival, almost 100%. Type 2, the risk of metastasis is higher, up to 30%, and the survival is determined by MEN1 syndrome. Type 3 is the aggressive one, and the risk of metastasis is very high, more than 50%, with 5-year survival rate of about 70%. This is the WHO classification that grades neuroendocrine neoplasms based on their proliferative activity. So G1 is well differentiated, where we rely on the mitotic count and the Ki-67 index, where the mitotic count is less than 2, with a Ki index of less than 3%. Grade 2 is moderately differentiated, and the mitotic count is between 2 to 20. And sometimes we subclassify that into low grade, where it's 2 to 10, or high grade from 10 and above, but the cutoff has not been well established. And a Ki-67% of 3 to 20%. Grade 3 is poorly differentiated, where the mitotic count is greater than 20, with a Ki-67 of more than 20%. I refer you to, so there's different guidelines, but I've been using personally the ENETS guidelines for almost 8 years, the European Neuroendocrine Tumor Society, and I find them very helpful in my practice. So I'll be focusing more on on type 1 and type 3. Type 2 is very complex because of the association with syndrome in the interest of time. But these are the characteristics of neuroendocrine neoplasm. So in type 1, as you can see, there is gastric body atrophy of the surrounding gastric mucosa, and you get ECL cell hyperplasia. The prognosis is excellent, as we said, and usually the majority will be presenting as a G1, but some could be G2. With type 2 and type 1 both have a high fasting gastrin level, and the chromogranin chromogranin A is high because of the gastric atrophy and also because of the hypergastrinemia that you have. But it's very important to recognize when you have a normal non-atrophic stomach or a normal chromogranin, or a normal gastrin, that this is concerning that you may be dealing with a type 3, which we know has an aggressive nature. Endoscopy is the mainstay because we detect these lesions in the stomach by endoscopy, and also endoscopy is helpful in recognizing if you have a gastric atrophy, which helps you to classify into different types. But also endoscopy is important because we need to biopsy the lesion to assess the proliferative activity, the mitotic count, and the Ki-67, and also to biopsy the surrounding mucosa to confirm if there is a gastric atrophy or not, and also the presence of ECL hyperplasia. Just to remind you that with type 1 MEN syndrome, we have association with primary hyperparathyroidism, pancreatic tumors, and pituitary tumors. From a lab point, we do serum fasting gastrin, and if the patient is on a PPI, routinely we should stop them for at least 1 week before we do that. And serum chromogranin is probably the most important test to do. And if it's normal, you should be concerned because you may be dealing with a type 3. Additional tests we do sometimes is antibodies for parietal cell and intrinsic factor, which could be associated with type 1, and also vitamin B12 and thyroid function testing to confirm the presence of autoimmune gastritis. EUS has an important role in these lesions. In type 1, for example, we assess the, as we heard from the previous speakers, we need to know the depth of invasion to know which layer is arising from and decide which management strategy we're going to go for. And also to assess the presence of lymphadenopathy, because that's also going to help us in having an informed decision. With type 1, we assess for lymph nodes if the lesion is more than 1 centimeter. And also, if it's less than 1 centimeter, but we have a high grade, high G2, then we also want to evaluate the presence of lymphadenopathy before we proceed. We also have a role for EUS post R1 resection. If you perform the endoscopic resection, you have positive margins, then EUS will help you to decide if there's any residual left. In type 3, again, it's very important to do EUS in almost all type 3s because you want to assess the depth of invasion and also the presence of lymph nodes because we know these lesions are more aggressive. Functional imaging is important in high-risk cases, so we perform contrast-enhanced liver MRI, also cross-sectional imaging, CT chest and abdomen, and it is important to just make sure that your radiologist is actually performing water ingestion immediately before the scan to improve the sensitivity of the test and enhance small lesions in the arterial phase. We also do functional imaging like a somatostatin receptor or a gallium scan. For the management, we recommend performing a multidisciplinary approach, and we know already from some studies that patients who are managed in a multidisciplinary team have a better outcome because these experienced group can actually sometimes result in changing the disease staging or changing the proliferative activity of the disease, which then can change the ultimate management for the patient. So I'm getting some flicking. In terms of endoscopic resection, we've already seen nicely from Dr. Shaima the different options we use for endoscopic resection. We know that ESD and full thickness resection have a higher rates of R0. And the other thing to just point out in type 1, even if you have an R1 resection, the ENETs recommend a step-up strategy where you can actually go from an EMR to an ESD, or from an ESD to full thickness resection, or from a full thickness resection into surgery. There is insufficient data on the long-term management of patients with non-interventional endoscopic resection. This is a diagram for the management of type 1. Let me see if I have. Oh. Sorry, I don't think you guys have been following me. We have a problem with. I apologize, they're just trying to fix it. Okay, so this is the diagram for type 1 management. So if the lesion is less than a centimeter and you have a low grading of G1 or low grade G2, then endoscopic resection is the way to go. And as long as it is negative, it's fine. If it's positive, then we still do a step-up approach, as I said. If the lesion is small but it's a G3, so high risk, then we need to perform an EUS to assess for lymphadenopathy and the depth of the invasion before we perform endoscopic resection. But in general, for intermediate size from 10 to 20 with a G3 or a large lesion of more than 2 centimeter, surgical resection is the right way to go. Post-endoscopic resection, the recommendation for follow-up, if it's a complete resection, to do it again in a year. And if the patient is not having an endoscopic resection, then they recommend to come back in a year and then stratify if you want to do it every 1 to 2 years. Just also to remind you that type 1 is associated with chronic atrophic gastritis, so these patients do have an increased risk for gastric cancer, and that's why endoscopic surveillance is important. For type 3, it's very different. We need to first stage the patient and make sure that there is no distant metastasis, and then depending on the size and the grading activity, there may be a role for endoscopic resection, but the majority of these lesions should be managed by surgery. And even if there is a full complete resection for that type 3, the surveillance should be in a much shorter interval, in 3 months, with a close follow-up and extensive investigation with EGD, cross-section imaging, and EUS, and have a low threshold for a functional imaging in the suspicion of a possible relapse. So I'll highlight a couple of cases. So this is a 54-year-old patient coming with reflux and for colon cancer screening with a previous pituitary adenoma surgery. Colonoscopy was normal, but his EGD showed a normal mucosa with a 5 millimeter nodule in the gastric body. Histology showed mild chronically active gastritis with parietal cell hyperplasia, most likely from PPI use, with a well-differentiated tumor, G1. So he had further investigation, and his antibodies were not elevated. Chromogranin A and gastrin both were elevated with a normal PTH and thyroid panel and ultrasound and MRI pancreas, because these patients have a MEN1, you probably recognize already, this patient has a MEN1 syndrome. So we performed endoscopic resection by ESD, and the patient had a full resection, and he's on regular follow-up now for almost 4 years. The second case is a 59-year-old female with iron deficiency anemia and vitamin B12 deficiency, and underwent an endoscopy and colonoscopy for her iron deficiency anemia, and shown to have a gastric body mucosal atrophy with a 12 millimeter ulcerated mucosal papule in the gastric body. Histology confirmed autoimmune gastritis from the surrounding mucosa with PCL cell hyperplasia. But the biopsy of the lesion showed a one mitotic cell with a Ki67 up to 4%. So here we're going slightly above the cutoff of G1. So we consider this to still be a low risk G1 to low G2. So the patient underwent further investigation with confirmatory test with elevated chromogranin, gastrin, and anti-parietal cell antibody, which is expected. But EUS confirmed that this is a submucosal lesion with no lymph node involvement. So underwent endoscopic resection, and so on the diagram this would be the case. So it's a 12 millimeter lesion, G1 to G2, EUS confirmed no invasion to the muscle and no lymphadenopathy, so went for endoscopic resection. And this is the lesion also removed by ESD. So in conclusion, ladies and gentlemen, Mr. Speaker, correct classification of the type of gastric neuroendocrine neoplasm is critical in determining what is the expected behavior of the lesion and which way to go for management. In general, type 1 have an excellent prognosis. Type 2 prognosis determined by type 1 MEN syndrome. And type 3, as we said, is very aggressive and has the worst prognosis among them. And remember that a normal chromogranin A is a concerning feature. Size of the lesion and the grading of the proliferative activity using the mitotic count and Ki67 determines the optimal option. And endoscopic resection in the majority of lesions is the mainstay. And remember that we can still do a step-up re-resection for type 1 with a positive margin. And these lesions are best served in a multidisciplinary approach for better clinical outcomes. And thank you again for the invitation.